Okay, welcome everybody. My name is László Ruskó. I represent GE Healthcare. I work in a data science group of GE Healthcare in Budapest, and I will give you an overview about one of our deep learning-based image processing project, which was about organ at risk segmentation in MR images using deep learning techniques. And this is the presentation that I'm showing was prepared originally for a scientific conference. Maybe it's too technical, but I would like to add some more information to make it more understandable for a wide range of audience. So yeah, what is radiation therapy, and why is basically organ segmentation needed? You know, if a patient is diagnosed with cancer, it is a very frequently used treatment option to irradiate the tumor. And this process requires very careful planning. And this planning is usually based on a 3D imaging modality, like CT and MR images are acquired from the patient, which can reconstruct cross sections of the human body, and this way they can build up a three-dimensional image which visualize the internal structures of the human body, including the tumor as well as the organs. And in radiation treatment planning, the tumor is irradiated and the surrounding healthy organs should be saved from irradiation. It's a kind of optimization process to maximize the dose inside the tumor and minimize the dose in the surrounding organs. And that's why in 3D images, the exact contour of the tumor as well as the surrounding organs should be defined. This is typically done in the clinical practice manually, which means that in each and every slice, the operators should carefully contour the boundary of the tumor as well as the boundary of the surrounding organs, and it takes a lot of time. And this can be facilitated by automated segmentation algorithms. There are already algorithms available in the clinical practice, and in the recent years, more and more deep learning based algorithms were developed, which are getting more and more popular in the clinical practice. In our project, we were targeting the manual or the automated segmentation of organs at risk in the head and neck and the pelvis region in standard MR images, which would be very useful for clinical practice because MR shows the soft tissue very well, so the tumor and the surrounding organs are well visible in these images. So that's basically the background. And here you can see some example. On the left side, you can see a head and neck examination. As I mentioned, these are cross-sectional slices of the human body. And on the right side, you can see a pelvis area. And here you can see we start from the bone, the eyes, and brainstem, and the mandible, parotid glands, oral cavity, spinal cord, swallowing muscle, and the mandible, and different important organs which should be saved from irradiation. This is an example for manual contouring. You can imagine how long would it take to draw manually all these structures. So it's a lot of time. Basically, it's a couple of hours or an entire day for one patient to contour these structures so accurately. And in the pelvis, you can also see a couple of organs like bowel bag, the bladder, femoral heads, rectum, prostate, urethra, and such important organs. So we are targeting quite a big number of head organs and smaller number of pelvis organs, which are frequently used in radiation therapy planning. When you would like to develop a deep learning-based segmentation, we need an annotated data set. You know, it's a supervised learning method where you have to specify training samples, which means that you typically start with collecting a data set. In this particular project, we have taken nearly 50 cases for head and neck and nearly 50 cases for pelvis. These were retrospective collected data sets. Some of them is publicly available. Some of them was collected in a private hospital. And here you can see the characteristics of the images. It's not so important to go into the details, but the point is that these images are very popularly used, were acquired with the very popular sequences. So it's not a very special MR sequence that we use. We try to use a very frequently used sequence as an input image. And here you can see that usually these images consists of like more than 100 slices with very high resolution of each slice. And we had to manually contour significant number of organs in these images. And you know, the number of annotated organs were varying from patient to patient according to the anatomic coverage of the scan. Here you can see basically an axial slice of head and neck examination, and this is a coronal slice. This is visualized in another direction, and the same for the pelvis. So this is the input that we are working with. And if we have the annotated image data, we can develop deep learning algorithms, and we can train deep learning algorithms to segment these organs. And this slide roughly summarizes the method that we developed. Basically, it's a localization and segmentation based approach. So it's like an example of multiple deep learning models. In the first set of deep learning models, basically does the localization of the center of the organ. Based on this information, we extract a 3D bounding box, which includes the entire organ. And within this small bounding box, we do a 3D segmentation with the 3D UNet, or in other words, VNet, to segment the actual organ of interest. In this particular case, it's the brainstem. And of course, at the beginning and the end, there is some pre and post processing. The goal of the pre-processing is to standardize the data to some extent, as the input images may vary in several characteristics like resolution, slice thickness, and intensity range and things like that. So we have to normalize them into a common range before we do the segmentation. And as post-processing, we can do such things like we can remove small separated islands from the segmentation, or we can fill like holes in a 3D object to eliminate the need for manual correction at the end of the process. So as I mentioned, this is an ensemble of 2D and 3D neural networks. And we have used the data set that we have collected to train this model. Approximately 80 or 90% of the cases were used for training, and the remaining 10 cases were used for evaluation. And we had to train, of course, the localizer, 2D models in axial, coronal, and sagittal direction, and we also separately trained the 3D model for segmentation. The model training was actually done in an average GPU, so these were relatively small models. And of course, we have used different type of augmentations, mostly geometric augmentations and intensity-based augmentations. And we actually used a very standard framework for optimizing the models with Adam Optimizer and varying learning rate, and we have used the dice loss. These are very standard concepts in the area of image segmentation. Once we have a model, we have a segmentation model, we would like to evaluate that. And we implemented different type of evaluation. The first one is a quantitative type evaluation, when we have the expected result, the so-called ground truth segmentation, and we compare the auto segmentation results with the ground truth segmentation, like pixel by pixel. We compare them, and we can compute different metrics like the dice similarity or the surface dice. One measures some kind of volumetric overlap, while the other measures the overlap of two surfaces, very roughly speaking. And these are very good quantitative numbers, and primarily used in many publications. So it's very good to compute these metrics, because you can compare your work with others' results. But we also wanted to pay attention to the clinical usability of these contours, so we performed a qualitative evaluation, which was done by clinicians, and they actually visually assessed all auto contours, and they rated the contours on a 1 to 5 scoring system, where 1 represented very bad segmentation or useless segmentation, and 5 represented perfect segmentation. This way, we could also measure the how the clinicians are satisfied with our results. And of course, we computed some statistics about these qualitative and quantitative metrics. When we have an evaluation methodology, we can do the evaluation. In case of a deep learning-based model development, we separate a small test set at the very beginning, which were never used for training or model optimization or best model selection. And we use these cases to measure the accuracy of the segmentation models. In the right side here, you can see one example for the 3D segmentation of one head and neck test case, and here there is another one for a pelvis case. And here in the table, you can see some statistics which show the dice accuracy and the surface dice accuracy and the clinical score for every organ. In each cell, you can see the average accuracy for computed over all the test cases. So it's an average number. And based on the numbers, you can see that like certain organs like brain and body or eyeballs are very well segmented, but brainstem and other structures are also show very high accuracy scores. However, in case of other organs like the swallowing muscle or the larynx, these are located here in the neck, the segmentation has lower accuracy. Similar way you can characterize the surface error, and here in the last column you can see the scores assigned by clinicians. And it's interesting to see that the different scores and the different evaluation metrics don't fully correlate. So it might happen that there is a structure which has very good dice accuracy, but this is actually rated very low by the clinicians. And this is due to the fact that dice accuracy does not always represent very well the error, what makes the clinicians worry about, basically. And that's why it is important to always compare your quantitative metrics with the qualitative ones. Just for another example, here you can see that based on the numbers, like the optic nerve looks very bad, like 70% accuracy, but it was actually rated well by the clinicians. So even though there are some inaccuracy, the clinicians didn't think that it's so relevant from medical point of view. And if we have a look at the pelvis cases, we see similar effects, like we have better accuracy measured for a couple of larger organs like femoral head and bladder, and lower accuracy for smaller organs like penile bore, prostate, or especially for urethra, which is a tiny little tube basically inside the pelvis. So in general, what we can say that for larger organs like body and brain or bowel bag, the dice a little bit overestimates the accuracy, and for small organs it can, and small or thin organs it can underestimate the accuracy. So that's why in the literature they usually characterize segmentation with different metrics, and they also include like a clinical score for the evaluation. Okay, here you can see some examples for auto segmentation, and this will show you very well while the clinicians scored lower or higher certain structures. Here, what we can see in the brain, we can definitely see some inaccuracies which require more time to correct. And that was actually the reason why the clinicians scored the brain down, even though the majority of the structure is very well segmented. However, if we focus on other objects like eyeballs, optic nerve, or chiasm, pituitary gland, or parotid glands here, you can see, or the PCM with this yellow, even though the accuracy is lower, what we measure, but based on visual inspection, the results are very good. So that's why we get higher scores by clinicians. But clearly, it's an initial result and should be proved in order to be used in the clinical practice. But please don't forget that we have only used like 50 data set to train our models. So this can be actually considered as an initial model, but still you can see that many of the structures are very well segmented, even though it was trained on only 50 cases. And very similar conclusion can be drawn for the pelvis organ segmentation. You can see the bowel bag, the bladder, the femoral heads, the rectum, prostate, urethra. So all of them is very well segmented. Okay. So in conclusion, I think we have shown that very different organs could be successfully segmented using the same or very similar segmentation framework. This deep learning framework that we have suggested proved to be very efficient, and in the clinical evaluation, we have seen that in some cases, for some organs, we can get very good, maybe clinically acceptable auto contours, based on this small data set that we use for training. And we also observed, which is not a novelty, that alone dice or surface dice cannot really reflect clinical usability. So a combination of different metrics should be used to characterize the performance of an auto segmentation algorithm. Yeah, and in the future, what we would like to do, of course, we collected much more data since this project, and we have added a lot more data to the model training. We have further optimized the training, and we've used much more augmentations, and this way we have actually developed more robust algorithms for head and neck and pelvis segmentation. This, as continuation of this work, we now have a very nice set of auto segmentation algorithms, which we would like to evaluate in the clinical practice in the near future. And of course, in the future, we have to extend the number of structures, as it was like a minimally viable product, which was presented here for the head and neck and the pelvis region. But in the future, other structures, organs, or like lymph nodes should be automatically contoured in order to make this package clinically usable. So that was my presentation, and if you have any question, you can ask, and meanwhile I can show some results. Yeah, unfortunately I cannot see any questions in the YouTube channel. So if the organizers can help me with the asking the questions, that would be helpful. If you basically interested in these topics, the auto segmentation using deep learnings, there are very good. I think it's part of your educational program as well, but in the net you can find very good courses available for free, which are about using and training convolutional neural networks. As a result of which you can develop your own solution. It's very important to mention that fortunately in the open or in the public era, you can find many published image databases. Some of them comes with annotation. Of course, in these projects, the annotation is the most important part. Since these are supervised methods. But otherwise, if you are interested in it, you can start like developing something and testing it for public databases. So it's not. I think today it has very good technical and theoretical background, and you can find basically a lot of tools, primarily in Python, to develop convolutional neural networks and train it and use them to segment not necessarily medical images, but also other type of images. Okay. If no more question, then thank you for your attention, and I hope that some of you will be interested in this topic, and maybe in the future we can meet